Good morning. It is my huge pleasure to welcome you to the second session of the CLINAM conference. It is my enormous pleasure to welcome Professor Patrick Hunziker to give the scientific introduction into the CLINAM Summit. If you attended the meeting before, he used this opening event to summarize in detail where he feels the advances of nanotechnology have been in the last few years, particularly as they impact clinical medicine. For the participants of CLINAM who never participated before, let me mention that Professor Hunziker was co-founder of CLINAM. He summarized, therefore, the advances from his clinical perspective, and you see it in the background. He is in the clinic every day, seeing patients. He therefore summarizes the advances with a unique clinical perspective. He became involved in medical applications of nanosciences in the late 90s, and has pioneered nanomedicine in Switzerland since then. Patrick has studied medicine at the University of Zurich in Switzerland. And then you went for a couple of years to Harvard Medical School. After you received your doctoral degree in experimental immunology from the University of Zurich, and then you did further research in experimental hematology at the Unispital in Zurich. I think, though, that your time in the US has really imprinted many experiences and perspectives that prepared you well to look into nanotechnology and new technologies, how to improve the life of patients. In 2008, Patrick became professor for cardiology and intensive care medicine at the University of Basel. And Patrick, we greatly certainly appreciate that you are spending the time because all your hospital beds are filling up and you see COVID patients coming in every day now. So the screen, not the floor, the screen this year is yours, and we are looking forward to your presentation, but also wishing you all the best for the very, very critical days and weeks to come in Switzerland. Welcome.
Thank you very much, Viola. Thank you very much, Beat, for all the efforts. You see, there are good reasons why we don't meet physically today in Basel. What we see, does everybody see the screen now? Now what we see is the deadliest natural nanoparticle in a century. And amazingly, a thing that is only 100 nanometers in size is able to bring down global economies and possibly major governments. This is an amazing jump across dimensions. And we are here in Basel, Switzerland. We have the world record in recent infections today per million of people. We are much higher now than we were in spring, as you see on the left side in the first wave. Also important is the perspective that not all continents are hit as hard as Europe at this moment. But the thing that where we are still now is that while cases have exploded, patients and deaths have not yet. But we know that hospitalizations and deaths have a delay of 1 or 2 weeks to the rise of infections. So we fear for the worst for the next few weeks here in our hospital. The mission of CLINAM Foundation is the same as it was from the beginning. We would like to contribute to the medicine of the future by advancing nanomedicine and the converging sciences to the benefit both of the patients and of society. What does this mean in the COVID era? Here you see one of our rooms a few days ago with a patient who has just recovered from severe COVID and is on the way out of the ICU. And the goals are, we would like to help those patients. But of equal importance is the fact that we need to protect the caregivers. And to achieve this for the societal scope, we need to understand and stop transmission of this virus. So I will focus this talk a little bit on this burning question of coronavirus interacting with nanomedicine, nanoscience, diagnostics, clinics, and converging sciences. So a virus infection is a simple thing. You have a person who gets a virus from the society, the community, and who will give it back to the community, to other persons. The person suffers from infection. After a few days, symptoms will develop. The disease may progress. The immune system responds most of the time, and this may lead to cure or death of the patient. But if you look at the coronavirus situation specifically, we see that this is not just a single medical specialty disease. This involves the whole range of specialties we have in modern medicine, starting from epidemiology to laboratory medicine to intensive care medicine, geriatrics, genetics, pathology, and so on. At the same time, the task for the healthcare systems is unprecedented. As a hospital, we have to stay functional. We have to allow access to those people who need it most. We need to innovate in diagnostics because this is a new disease. We need to find effective therapies, and we would like to figure out how to prevent the disease such that people won't need to come to the hospital. So the converging sciences, for example, biology, applications of physics, pharmacology, mathematics, computer sciences, and others play a major role in this new understanding of this novel disease. Now, this virus, as I have already mentioned, has a major impact on the economy. The virus may lead to lockdowns, as currently taking place across Europe. Lockdowns change the social interactions. They may decrease the risk that you infect your neighbor, but it may increase the risk that you infect your family member. Home office, we have a market downturn. Then we have the policy questions of foreign competition, competitivity, state aid, and all the other where I'm not the specialist, but our politicians need to focus on these questions also. What are the emergency measures they can take? What is the weight of social control versus freedom in a society that may propagate infection? How should the government fund research into this new disease? What are the economic measures that can be taken? What are the international relations, unemployment, and even civil unrest that we have seen in some cities where people protest against wearing masks? Then we have the diagnostic industry that should provide new tools, but at the same time is suffering from lockdowns. We have the pharmaceutical companies that usually take 10 years or 5 years to develop a new drug, but now they should deliver it at once. We have the medtech companies that are required to deliver equipment for intensive care use to treat the sickest patients in minimal time. But let's not forget there is also a north-south divide. Healthcare systems in the south are in a limited capability to provide care. They cannot provide access to everybody. There is little research done in poverty in poor countries at the moment, and the availability of protective equipment is very bad in poor countries. Let's try to understand transmission of this virus. So we know that we have micro and nano objects, droplets and particles. We have patients where anatomy and physiology plays a role. Then we have architecture, aerodynamics that play a role in transmission. We have the computational science. We have the behavior of groups of people and environmental factors, which already show you the simple question of virus infection is not just the virus jumps from you to somebody else, but it's a real complex task to understand and to manage. We are doing that by trying to understand what happens in these rooms where I'm staying and working now. For that, we have built 3D models of our rooms that you see on the right side of the screen. And you see the floor plan and the wall plan below. And we are using these 3D models now to model airflow, air conditioning in our rooms. And what we have found is that in a standard ICU air conditioning situation, meaning 10 room exchanges per hour, we have a relatively steady flow. But we also have some vortices. For example, here we have a vortex coming from the patient bed to the nurse workplace. For example, here we have a stream from one patient bed to the next patient bed. So we have moderately laminar inflow, which is unstable to minor disturbances. As you see, at some point this shakes a little bit like now. And now let's have a patient who is in this bed cough one time. We see the cough jet, the cough velocity jet. The head is tilted a little bit to the right side. And what we see is in the first real-time 3 seconds, a rapid jet, followed by 5 minutes of time-lapse imaging of the air in this room. And what we observe here is we see a cough jet moving across the room. We see the buoyancy of the warm air exhaled by the patient moving upward. Here we see the warm air moving upward. And then we see that the disturbance induced in room air conditioning by a single cough that ripples across the whole room. Now let's look at what happens to the exhaled air. The exhaled air moves by convection and diffusion, and what we see that within 5 minutes, the exhaled air is everywhere in this room. So in an intensive care unit with a high ventilation setting, nevertheless, we distribute exhaled air to each place in this room. Now, does it matter if the exhaled air goes somewhere? Aren't it the viruses that are of more important? For this reason, we have now moved to modeling particles and droplets. And here you see such a particle and droplet modeling from the same patient bed down here across the room. And what we observe is two major things. First, as we see in a moment, we see the first 3 seconds of ejection. Here, that means within 3 seconds you spray the room at a distance of 6 meters with ejected droplets, but then you have a plume of other particles that slowly move across the room and are distributed at many places. Now these secondary particles, they do not fall down near the bed, but they tend to travel with the jet, but then they still may fall down on the next patient's bed, and they may fall down and move into the nurse working place location. As a next step, we have done this analysis in a size-dependent fashion, which you see here encoded in different colors. What we see is that droplets of 1 millimeter size that occur in a cough, they move a few meters, 2 to 3 meters. They move during 3 seconds and then they are gone. Droplets that are smaller, 100 micrometers, they are slowed down by the air and they drop down much nearer to the bed. But then comes another dimension of droplets, and I call them the jet rider droplets, because they are capable to travel with an air jet, but then they still precipitate on the next patient's bed and on the nurse workplace. And this is true for droplets down from about 40 micrometers down to about 5 micrometers. Below that, you have an aerosol behavior. There is no falling down of droplets anymore. These smaller things like single particles of submicrometer size, they just travel with the air wherever air conditioning demands. Now here we have looked at the exposure of bystanders. That means we have taken the room space where a head of a nurse can work, and we have looked at the time distribution of this peak exposure. Here you see the big droplets in brown and in blue. And you see that the droplets, they are gone in 3 seconds. That means if somebody coughs nearby you, you turn your head, you wait 3 seconds, you turn back, then the cough is gone. But the other problem comes here. These jet writer droplets, they stay in the room for up to 300 seconds. And if you accumulate those droplets, you see that the largest, by far the largest exposure of the bystanders is by these jet writer droplets in this range. Now, unfortunately, our nose is built to extract particularly those droplets exactly in this size range. So we have the ideal anatomy to capture such jet writer droplets in our nose. Now, as a next step, we have modeled the cough, as we have already shown you, but we have correlated that with real-time nanoparticle imaging. So what you see here is a patient, not a patient, a volunteer. And here you see his nanoparticle exhale plume occurring within a second, within 3 seconds, and then within 30 seconds. And what you see is the very same. We don't see any droplets here because we don't image them, but what we see is that this particle, small particle plume, really goes across the room. You can also look at that in a kind of video that tells you why, if somebody smokes, you smell the smoke across the whole room, showing this this particle everywhere. Now we learned that coughing is bad. Unfortunately, if you try to shield this cough, this does not help. The shield just disperses the jet everywhere. And this is also the reason why such face shields are of little help of avoiding infection, because the air just enters down here to the nose and there infects the patient. There are ways to achieve full source control for emission of infectious material. That requires new approaches, and we have found some ways to do that. The next step is the enterprise scale. The University Hospital of Basel has 2,000 people. We would like to continue working during this pandemic, but we need to protect us. And that's why we have built a model of entire units in our hospital, and we are studying the travel of people, the encounters that are possibly transmitting encounters in this room, to adapt our schedules, our ways across the hospital to minimize this approach. And what will also be needed is the question of looking at the village, city, province, country scale to figure out what happens to these patients who spread the disease everywhere. Here I show an example of our malaria model that is similar in scope because it models time, persons, immunity, pathogens, communities, weather, and environment. And we need to expand this to coronavirus injection. Here you see an unprotected society. The red parts are persons who are infected. And here you see some cattle, some mosquitoes, some transmission, and you have more mosquitoes, and the infected persons never are reduced in number. Now, if you have transmission blocking strategies, you still have some red infected people, but over time you show how you can eliminate those infections. And what we see is that transmission blocking is really effective in eliminating disease from the community. Now, it has been studied in many countries what policy effects are most effective. School closures, public events ban. You may look this up in Lancet Infectious Disease of the last week. The herd immunity concept is questionable because those areas in Brazil that were hit strongest in spring, they are now hit again strongest, so they don't benefit from herd immunity. Understanding the impact is also a multifactorial problem. Just one slide about the economic impact. It has been estimated by ETH Zurich that 1 or 2 months of COVID-19 pandemic in Switzerland costs about 30 billion Swiss francs. Now compare this to the research funding in Switzerland for COVID, which is 10 million in the first call and 18 million in the second call. So we have about a 1,000-fold reduction of the money spent for research to master this disease. Now let's go to testing. PCR testing is the gold standard for COVID. It's highly sensitive, time demanding, costly. It will even be positive in viral load and beyond the infectious period. Now what happens? You get the virus at day 0, you develop a systemic viremia on day 3, you get symptoms on day 4, you go to testing on day 5, you receive the result on day 7, and when you get the result and go to isolation, the infectious period is almost over. But the test will stay positive for maybe up to 2 weeks. Now, what's the importance of sensitive versus less sensitive testing? Here we have looked, no others have looked at the impact of frequency of testing and test sensitivity. Let's take a less sensitive test. It will nevertheless be positive during the time period when you are infectious. Now, if you apply it once every 2 weeks, there is little impact on disease propagation. If you apply it weekly, it's a little better. If you apply it every 3 days, then you get higher suppression of infectivity. And if you use it daily, it actually doesn't matter too much how sensitive your test is, because you still capture most of the diseases and can avoid infection. So if you have a non-surveillance society, as we are now, you get huge numbers of patients. If you survey them with a sensitive test or a less sensitive test, you get a significant reduction of the case numbers. But in the end, if you have a less sensitive test that you use very frequently, you can really slow down the infectious period very much. So the potential future paradigm may be you only go to work after your daily rapid self-test is negative and you feel well. This will save lives and it will save the economy. Rapid testing options, LAMP, test strips, maybe imaging, mass spectroscopy, but also disease detection. If you lose your smell or your taste, but have no stuffed nose, you have an 80% probability of having COVID today. Imaging can be done by computer tomography, as we do it in the hospital. If we have patients with respiratory symptoms, maybe in the future we can look at spectroscopy methods. For example, single particle spectroscopy described by Professor Delguedre. Clinical management. Unfortunately, antiviral therapy has relatively little effect on outcome. And understanding what are the factors that make you sick is so important. It seems that the immune system plays a role not only in combating disease, but also in promoting the disease. So we see that interleukin-6 is significantly increased in the patients. But modulating the immune system by hydroxychloroquine is not beneficial. Steroids have some effects. Immunomodulation by IL-6 blockade does not help. And recently we have learned that there are some loci in the genome that predict disease. Now I will jump a few slides of machine-assisted ventilation and finish with the vaccine effect. Vaccines are the big hope, but they are no promise. Vaccines are similar to viruses, except that they do not kill and do not damage organs. They lead to an immune reaction, as we see here. But unfortunately, also the coronaviruses have a large spectrum of evasion mechanisms. And it seems that you can get infected by coronaviruses every year, as seen in this cohort. So we see that to treat this epidemic is not sufficient to treat the body. We need to think about our thinking, and we need to think about society, politics, and interaction with other social beings. Let's not forget that COVID-19 is a globally spreading disease, and protecting us also requires protecting them using adapted approaches. Otherwise, the disease will return to us too. Thank you for your interest.
Thank you very, very much, Patrick, for an outstanding talk. Showing your simulations is really an eye-opener, I hope, for all the COVID caregivers, but also for the rest of society, because the same spreading happens in restaurants and bars and all other closed rooms. Thank you. So with this, we would like to return the screen to the next session, because there were no questions asked by the audience. In the future, please use this button to ask questions if you have some during the talks. Thank you very much.